We're both healthcare providers in Alberta Health Services. And we're invited on behalf of the new CEO, Mrs. Vicki Kaminsky, to step away from our jobs and our roles and look at the continuing care system.
My name is Nick. I'm a retired registered nurse. And I was reading the papers, the daily papers, before I came today. And I saw something that I hadn't seen before. Something about the General Hospital doing a big revamp. Their staffing shuffle, where they once again are going to replace higher level, higher trained staff with, like you were saying, 70% health assistants, you said. Apparently this is going to happen again. Can you enlighten us? Have you heard? I've never heard anything about it.
All I know, John, is what I saw in the paper as well. So we are actually going to a Covenant Health forum on Thursday. So we should be getting some more information at that point.
You've hit most of the points that I think we're all sort of looking at. The question, of course, is when might the recommendations come forward?
Well, I'll answer that one. We actually finish our secondment at the beginning of January. So we've tabled some draft recommendations just this morning, but we haven't had the opportunity to share them with our internal people yet. So I would say in the coming days, they will be, or we're going to validate them with all the people that we have met with, including your group as well. So coming days and weeks.
Just a supplementary. In your dissertation, you mentioned something with respect to under the work plan, under patient and people. You mentioned something about family advisory councils. What is that?
So in the continuing care standards, and they are available if you get on the Alberta Health website, it says that a facility must have a residence council. So for many of you that maybe have had loved ones in a facility, they have to have a residence council. And what we have found out in speaking with families through this process is that they're asking that there be family advisory councils set up so that there's an avenue for the families, particularly if their loved one is, let's say, cognitively impaired and doesn't feel that they can speak for themselves, that there's an avenue for the family to bring concerns up or suggestions, or vice versa, the facility, let's say, for example, what you read in the paper, I didn't read the paper this morning, but what you read in the paper, would it be possible for that, if they're changing their staffing models, because we're hearing actually some facilities are saying, we need to actually add staff in the nighttime because of sundowning, and so, you know, we have a lot more activity at nights versus days. So instead of the families finding that out in an indirect way, why don't you sit down as a family advisory council and say, here's some of the changes we're thinking of doing. We're thinking of changing the menus, we're thinking of changing the staffing model. What do you think about that? What do we need to pay attention to? Isabel and I have had the privilege of actually sitting down with one pretty powerful family council in one of the facilities in this province. And we were actually in awe about how they were structured, how they were able to bring issues forward, hear the concerns of other family members or other public members. And it really actually was a very, I think, a really good approach. So we're actually suggesting now that not only resident councils, but you have a family council as well. Or if you're the power of attorney or the decision maker, you know, it might be a friend or somebody designated, absolutely, let's have that.
Okay. I'm neither a family or a caregiver. I am an inmate. And I actually live in a continuing care facility run by Alberta Health Services. I was lucky enough to get the Sage newsletter on Sunday. And that's why I'm here today. But I can't stay late because I have a dad that picking me up at 3:30. Everything that you mentioned is absolutely true. It's really a problem. I've been in a facility which is not my own home for a year and a half, but I've been qualified to be in that facility for 30 years. I stayed in my own home until last year, and I have really had my eyes opened by being in a continuing care facility. And I use the word inmate advisedly. It's just unreal things that are happening. The biggest problem in my facility includes everything you mentioned. However, our facility is for people who have lots of money. And I was smart enough to start saving when I was about 17, because I knew that I had a condition which nobody would be able to deal with eventually. I was going to die 60 odd years ago. Didn't do it. And I did manage to still be here. And now I found out that nobody knows in any of these facilities how to help me physically, mentally, emotionally, nor do they have the time to spend to find out how. Every staff person who comes in always says, initially, we are too busy, we haven't got time to listen to you. So when you talk about communication, I have found out that they really haven't got time to listen to the actual people there. I have my own caregiver who is here right now helping me with holding this microphone because I can't do it. And if I were not financially able to pay people who will help me and listen to me, I would have been dead by now in this continuing care facility. The biggest problem is the food. They don't feed people correctly. They do not give you enough iron. They do not give you stuff that is fresh. They feed you stuff that is canned. It's full of salt, it's full of sugar, and then they can't figure out why people get bed sores that cannot be fixed. And the part of it is that they haven't got the strength to fight it. I won't eat it. My caregiver makes meals for me. We take them downstairs and eat them at the resident staples. And every time we do that, they say, "Where did you get that? It smells so good." What do you do? I wish you every bit of success. But until they improve the staffing levels of frontline caregivers and give them time to run in the room and say, "What would you like?" and listen to your answer, that is not going to help. they've got to give us enough people who will actually listen to us. And if you have bed sores or whatever and need help, I was fortunate enough to have brought medicine with me that I use, but I'm not supposed to do. But I've been down, for example, on a Friday afternoon saying, I would like something because I'm throwing up all day and I need something now. And I've been told, oh, you'll have to wait till Monday when the doctors are back. Thank you for listening.
You know, I think, is it Donna? I think your concerns, we've heard similar concerns, and we need to do better and we can do better. And I think by having this conversation, by opening the kimono and telling the story, that's how we'll make the changes.
My question is more on your report card and the system monitoring, or the system, we talked about quality improvement. I'm just wondering if you thought about monitoring and the appropriateness of that. Just because my experience in being a contractor of a program that helps people under 65 who live in long-term care participate in the community, there's a huge range in terms of the quality of care that people get in long-term care. Some are getting fabulous care, but some are certainly getting far less. And so I wonder about the monitoring, so if you could speak to that. Then the other concern I want to share with you, which I'm sure is on your radar, but you didn't mention it today, and that's the changes to the federally, to the foreign workers program.
Yes.
That potentially will drive a whole number of people into long-term care if it doesn't get resolved. So just wondered if that was addressed at all.
It actually has come up. Thanks, Taryn. That actually has come up, and certainly is a threat, I think, to our current system. And in terms of monitoring, we have put forward this morning some ideas around audits, streamlining audits, and just, you know, a focus on quality on the front door, at the front door. I think we need to focus on quality improvement as opposed to, you know, after the train has already left the station. So there's a lot of work to do there.
We've actually tabled some, we're tabling some examples that we've seen actually of quality at the front door. So if you walk into a facility, you'll see this is their quality roadmap, this is what they're monitoring. So you can see, like, I saw a facility that, you know, they were monitoring their hand hygiene. Well, that's pretty important. If our staff washing their hands, or the hand sanitizers available, their falls, their responsiveness to concerns. So, yeah, quality at the front door is kind of what we're labeling it. So, yeah.
I've been very interested in listening to what you've had to say. It seems to me, you know, if we're going to resolve the problems with the continuing care system, we need to look at the kind of problems that individuals have, and I think that's largely what you've been hearing, but we also need to address the systemic problems, which often individuals are not in a position to speak to. And when I'm referring to systemic problems, I'm thinking of things like the difference in delivery for publicly delivered, non-profit delivery, and for-profit delivery. We've seen the huge differences in healthcare because of the move to private for-profit delivery. Other systemic problems are, for instance, Minister Beeper in 2008 capped the number of long-term care beds in this province, and we've been following that for 6 years, despite the fact that our population's gone up by, what, 600,000 since then? Are you looking at the systemic problems as well as the individual problems, is my question.
For sure, that certainly has come forward. And, you know, there's there's a funding formula. I don't know if you've heard anything about the funding formula. So there's certainly been a lot of attention on the funding formula. But I think the other piece that really needs some attention is the amount of funding. So there are two issues, right? One is the funding formula, sort of how it gets allocated, and then how big is the pie. So I think there are two pieces to that. And then I think just the whole transparency. I mean, people need to know how the decisions are being made.
And I think the other thing that I think you were referring to from a systemic is how do we actually plan for the capacity that we are going to need and ensure that as best as possible we're putting that capacity in the areas where we're going to hopefully respond to the greatest need as possible. But that's a moving target as well, and that's why we're seeing some of the kind of innovative models happening in the rural sites where they're taking some of their facilities and saying, okay, how can we actually look at that facility a little bit different? And the communities are actually very excited about that. Yeah. So in the southern part of the province, they way ahead of Alberta Health Services being born, they actually were looking at how they could use capacity in their rural facilities. And we've seen some really positive feedback about that. So again, is how do we match the capacity and making sure that we've got, whether it's a privately funded or it's a private operator or an AHS operator, have we got the capacity in the right places to meet the needs? And as you know, our province is growing.
Hello, my name is Anna Looms, and I've been wondering why. You said Alberta has more dementia than other provinces. Why? How much care do we give to the food we get, to the chemicals in Roundup, in water and air? Why are we talking about continuing care, which is really a band-aid for the problem we are not stopping? We are allowing things to happen here in Alberta that would not be allowed in other parts of the country or the world. So why are we getting the food that is poisonous?
So I think when I said it was the young dementia that we know is the highest here in Alberta. Good question. I don't have that answer to why. However, you know what, it might be actually interesting for your group to actually invite people from public health and the agriculture to actually have that conversation, because you're asking some pretty powerful questions.
I heard you say we have a new premier. Was that supposed to indicate that everything's going to be okay now? Or is this during politics?
No, I was just saying that there's a lot more.
There isn't anything that you can say or that you can do that's going to change anything. You ask the people here that ask you a question, you're not going to change a thing. Because it's not a healthcare system for the healthcare. It's a profit system for making money. And the pharmaceuticals are making billions feeding our seniors pills that they should never take. I have a friend, his mother was in that Capilano on the Gretzky Freeway, and his mother was in there. She wasn't being fed well, and she was in a dark room, and he went in there, and I was with him, and he wanted to move her, and she barred him. She said, you get out of here and don't come back, and if you do, I'm going to call the police on you. That's what happened. You're not going to stop that. There's too many people making big money on this thing. They're not worried about the patients and the seniors. I was also in the Glenrose, and when you're in the Glenrose, and if you didn't take the place they told you to go, you had no say at all, none. You had to go where they told you. Was that for some doctor that had an interest in it? Or what was happening there? How come the patient couldn't decide whether you at least have a say where they're going to go? You're barking up the wrong tree. You're not going to do any good here at all. It's just only for window dressing. And I've lived too long to see it any different. But good luck.
Thank you for your comments. And no, and I genuinely mean that, because I think what Isabel and I have, as we said at the beginning, we're very humbled by this whole work that we've been asked to do, because we're going to do our best to try to be a collective voice, to take the messages that you give us today and that we've heard from the 900 people. Are we going to be able to change it overnight? Likely not. But we're willing to listen. We're willing to get your feedback. And I think what you're saying is that, you know what, let's not make it complicated. Let's not make it political. Let's do the right thing, because it's the right thing to do in the name of patient care and good patient care. And we can learn a lot about things that we wished had not happened. And we need to change them.
But he was kicked out of there and he couldn't go to see his own mother. What kind of a system is that? Can you tell me that? Maybe you can answer them.
Yeah, I mean, I can't speak to the specific
Well,
circumstances, but you know what? We need to focus on person-centered care, and that means families, the resident, all those people that surround him.
They kicked him out.
My comments kind of follow along with what this gentleman just said, because I think continuing care is becoming a big corporation for a huge, not little, a huge profit business that doesn't care about the people in their institutions. Example, laying off the staff to replace with low wage, no benefit, part-time staff who can't properly deal with the inmates, so to speak. Example, Shepherd's Care, which was supposed to be a religious-based facility. They just finished going through that. Now, as the population continues to grow, so will the big corporations' profits. If the big corporation doesn't make a profit, they're not going to offer the services anymore. So can the government step in to offer it in its place? I kind of doubt it, because they're sort of it looks like they're hand in hand. There's lobbyists and things that play behind the scenes that us poor people who are going to be going into these systems pretty soon, we can't do a thing about it. And hopefully it's not window dressing what you're doing, and if you really truly want to help the people, it's nice to say all those things up there, but it's not going to help when it's only being done for the money. Second thing that I think is a real big problem, because I feel like I'm in this class, we're classified as lower middle class. We're in a huge, huge mess, because the cost of living, which when they factor it in, do you realize, well, I realize they don't take the cost of food and the cost of gas and stuff like this, that's not factored into the cost of living, and it's still rising rapidly. And the cutoff for subsidies should be reviewed and raised to accommodate these forgotten people, because we're going to end up as being so poor, we're going to be basically left out on the streets to fend for ourselves, and we can't, because we're getting weaker. It's too bad. I really hope you can do something for us. We need your help.
Thank you very much for your comments. You know, some provinces have actually established means testing, and Alberta hasn't done that yet. I don't understand if there are any plans around that. But I think that it's only by having these conversations that we start to build awareness about some of the issues that people are facing, or what the public will be facing if we don't make some changes.
Thank you, and I just want to say I was one of 12 people who put in a letter to the Auditor General 10 years ago, and they told me after that they went into the nursing homes at 3 o'clock in the morning, found out they were getting those people up and dressed at 4 and 5 in the morning to save staff during the day. So my first question is, have you gone in those hours of the morning to find out what's happening? Number two is, I think that I was absolutely shocked to hear that Donna is paying personal care your own personal care person, and I'd be interested to know what that is costing. But secondly, I heard on the weekend somebody who was working in a multi-handicapped home in southern Alberta and told me that their families are being encouraged, quote,
to hire in their own personal caregiver at night and to sign a waiver. Is this what's going on around Alberta? If it is, and Donna, I'm shocked that you have to do that. I want to know how much Donna has to pay.
Do it for me. I would get $80,000 to $100,000 a year. 80 to 100,000 a year. But that includes weekends, because there's care on weekends is casual, never the same people, never the same shift. Never the, we've got a nursing director on holiday for 2 weeks. Nobody is getting in the nursing care.
My name is Eileen Taylor. I wanted several points on the matter of funding. The reason we all pay taxes is the government's responsibility is health, safety, and education. And the wealth in this province from resources is supposed to benefit everybody. But our government is spending, well, allowing a lot of the services to be provided by private providers, and they shouldn't be. That's the first thing that has to be changed. And they need to change the tax system, because those who can most afford to pay are not paying their fair share. And so old people are left in terrible conditions. The government needs to put the money into building itself, not paying half the cost of private developers building long-term care beds and so on. The government has to do it. It can borrow the money more cheaply. It can do it more cheaply when you take the profit motive out. And a great deal of money is spent on Alberta Health Services. What kind of expertise have we got for the kind of money we're spending? We have a health minister now who doesn't know the first thing about it. And it would be much better to have people who have expertise, nurses, nurse administrators, and so on. And a special concern, a lot of our long-term care centers don't have sprinkler systems, don't have enough staff at night, don't have escape plans. Surely the first thing that should be done is money should be spent to make all our care facilities safe in case of fire. We don't want everybody, all those old, frail people, to burn to death. So they've got to get their priorities straight, and they've got to raise the proper funding and spend it on people.
I had a question. I actually asked this our Rick McIver during the Conservative leadership campaign. If you read the financial pages of the newspapers, you see that long-term care is touted as an extremely good investment. Sort of the next best thing to printing your own money. But if you raise the question of maybe these places should have sprinklers installed, and the operators say they can't possibly do this without government assistance for the funding. Sort of those two don't seem to line up.
We were actually at a meeting, I think about in the last 2 weeks anyway, where there was some discussion with the Minister for Seniors, the Honourable Jeff Johnson, about sprinklers, and certainly the Minister at that meeting acknowledged that the government was committed to making some changes, and I think there's already been some money that's been allocated for that, but I think to your point that there's probably more that needs to happen.
Thank you very much, Mayor Shauna.
a few comments based on what other people have said. My mom has advanced Alzheimer's. She's at the Edmonton General, run by Covenant Health, and they have recommended she get a companion for meals. So not for outings and such, but for basic care. So an interesting detail is that she got a companion through Covenant Health. So her estate pays $20 an hour, $8 stays with Covenant Health, and $12 goes to the companion. For things that I would have expected Covenant Health to provide. Covenant Health, they're changing the staffing, and the staff are very concerned about bumping. And for sure there's all sorts of stories, but having been there yesterday, the staff were meeting with union and such, and their biggest concern is that bumping has to do with seniority. So the staff were saying that they got specially trained for this Alzheimer's unit, and that has nothing to do with who's going to be there. And the last time there was bumping, 10 of the 20 staff changed within a 1-month period. That's not good for anybody. And it's going to happen again. And it'd be very interesting what they say to you at your Thursday meeting. It's hard to understand how that's good. You had said, this was the question, you'd said that there are 24 ways to submit concerns. I've submitted concerns and actually been banned. Currently I am banned. I got everyone involved possible. The Ombudsman responded saying it's not been fair. The Auditor General's report that came out last month says the Ombudsman doesn't have any further authority. I spoke to the Seniors Advocate. He has no authority. So who in fact has authority to ensure, if the Ombudsman says it's not fair, but has no further authority, could you direct me to who would have authority if there's 24 ways to submit a concern? And sorry, just one other thing. The Seniors Advocate said, we accept all complaints, but we have no authority to do anything with it. Thank you very much. Thanks.
This feedback is always good so that we know next time that we explain when we make statements like that, but thanks for bringing that up. So when we were told there were 24 ways to bring a concern forward, that can be 24 ways in a variety of settings. So the ministry may have their concerns processed, which you've obviously experienced. The seniors ministry may have their concerns processed. Alberta Health Services will have their concerns processed. Covenant Health will have their concerns processed. Not done yet. And then facilities will have their own, so the operator may have their own concerns processed. And then on top of that, you may have advocacy groups, so the MS Society, the Alzheimer's Society, the Seniors Council on Aging. We found out there was an issues management portfolio in one of the ministries that just came to light. So you're right, there are many, 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 many avenues around how the concerns process. People can bring their concerns forward. And I agree that it is very confusing. So I'll let Isabel talk about the accountability.
But who can address it?
The accountability piece, yeah.
I think from the accountability perspective, because I did follow up on the ombudsman, and his role is really to basically identify whether due process has taken place.
And he ruled if the process didn't take place,
Okay.
but has no further authority to compel the facility. And I did go to the seniors ministry and the AHS and the health minister. I did all of that. It's been years. It took the ombudsman 3 years to investigate.
Yeah.
But I'm still banned.
That's terrible.
Banned from going to the general? Or
Banned from visiting my dad, and they will invoke the Trespass to Premise Act if I visit my mom for more than 1 hour. Or if I visit friends who've submitted requests that I visit. So it's not fair. It's been determined it's not fair, but there's nobody with any authority to compel them to correct wrongdoing.
I would
And
say-
based on, sorry.
I would say ultimately it's the CEO of Alberta Health Services for and Covenant, because that's a bit of a
Well, and the
complication.
CEO was involved with the ombudsman. So the ombudsman communicated with the CEO.
Okay.
So the CEO was aware of it's unfair.
And have you had a response from back from the CEO then?
She's been bad.
Just the ombudsman, other than the ombudsman, will investigate. So there's no follow-up. Like a letter saying it's not fair, and that's where it ends.
Okay.
So who has the authority to ensure correction of wrongdoing?
I would say it's the CEO of Alberta Health Services.
Or Covenant.
Well, Covenant doesn't feel they've done wrong. I mean, it's been determined they've done wrong by the ombudsman, but Covenant Health has said they're independent of AHS.
They're independent of ages.
Yes, they are. Yeah.
So then sending me through the AHS process doesn't make sense.
We'll have to do some more homework.
Thank you.
Get
Do some
your-
homework.
I did get your phone message and you did start to make some calls.
Thank you.
Yeah.
Thank you, Sean.
Thanks very much.
My name is Bob Atchison. I guess the question I have is, in all the materials that you presented, there's absolutely no discussion at all about the impact of the inadequacies of continuing care and long-term care on the active treatment facilities, the hospitals. Every time I've been in the emergency, I swear that at least a third of the emergency beds were taken up by seniors who had been shipped in because there weren't any healthcare people within the facilities to deal with relatively minor issues that should never have appeared in the emergency.
My apologies, that was an oversight on my part, because I was supposed to talk about that in one of the bullet points, but can I respond to you?
Sure.
So we absolutely have recognized that we need to look at the support and the resources that are available to have care in place. So and we've learned this again, Isabel and I, through feedback from the meetings we've had, that we need to support facilities so that we have appropriate transfers to the emergencies and admissions. So in some of the communities right now, they've got these great programs called community paramedics, where they have trained specialized paramedics. It's a similar program that they've done in Nova Scotia, where they bring them into the facility versus you transferring into an emergency department. And they do your blood pressure, they'll take your blood, they'll check your heart, and they'll say, you know what, I think we can manage you here, facility, are you okay with that? And they'll also build some expertise and capacity for the facility to care for the person. So we know we need to do more work on that, but we've had some early successes in Calgary, where I work, where we've actually reduced the transfer to the emergency by about 80%. And it's because we put nurse practitioners and specialists, we've kind of virtually and physically moved them out into the facility. We also know we need to do better work when we do have a senior in the hospital and when we do have them in the emergency department. And that is one of the other suggestions that we have made, that we need to equip staff. What does it mean to care for a senior in the emergency department? Toileting, mobilization, giving them fluids, getting them up. And same with when they're in the hospital. I admit, because we don't do a good job of that. So both sides. So thank you. I apologize. I meant to put that in when we were talking about the delivery of models of care. That was one of them. Thank you.
My name is Amelie. Thank you for coming and
talking about what you intend to recommend to the government. I only hope, just like one of our speakers say, that it's not only window dressing. After having listened to so many speakers, I'm very thankful to all of you for expressing the concerns quite loudly about what is happening. It's actually, I do not have much, but I think the problems go further back. And the problem has to do with the fact that it's a branch of healthcare that has, not only healthcare has always to do with people. And with people you need to do whatever you recommended. Now, about the system. Sure enough, you can say all you like, but you just cannot tell people who are manning the positions to get out. We are going to employ those we think are fit. So what do we do? First and foremost is whoever the government wants to employ, it has to be people who are caring. Also that supervisors, they have to have the courage to shuffle around their staff. When I say that, I think it's a humane way of not telling, of not firing certain stuff. There are certain work in every organization, and more so in an organization that has to do with human beings. That there are staff who are not humane enough to do work which is needed for them. And even before that, when you hire someone, away with nepotism, away with favoritism. So, well, of course, with the merit, there are also various ways of getting around that. But I still think that another problem is communication. In departments, they have to be maybe re-established, and we need people, good leadership. That I'm talking round. Because I'm so happy today to listen to all of you, and that you are, I hope, listening to us, and the rest who you bring them. It's horrible. We have to go through so many hoops. Yeah, and horrible for this lady also. My God, it's really, I feel for you. So, that's all I have to say. I don't know what you can achieve, but I hope that something can be done somewhere. And it's not only with the healthcare, everywhere.
So we're creating a movement, and we need every one of you behind us. I think the invitations we've had to speak to people and interact with people, and these aren't invitations that we've said, can we come and talk to you? People phoned us and said, we'd love to hear from you. We want to give you ideas. You know why? When they said, I think we could start a movement. So we need to get continuing care on the agenda, and we need your help. And I think the energy in this room today, the questions that you've challenged us with, the comments that you have been so open and honest with us, thank you for doing that, because not everybody feels comfortable with that voice, and we need your voice.
I just wanted to also, it's Amway. I just wanted to also assure you that we have been meeting with the CEO of Alberta Health Services, Mrs. Vicki Kaminsky, almost every week, updating her on what we're finding, what we're hearing from people like you and people that have sent concerns in. And so we have been building a dialogue. We have been building momentum at the very senior level of the organization. And I mean, people can't ignore this. We need to turn things around. And if we don't do it now, it's going to be too late. So Thank you very much.
Thank you. I'm Bill Martin again, and I'm the Executive Director of Public Interest Alberta. And we've been doing advocacy work on seniors' care issues with many people in this room for years. And I'm actually very encouraged by your approach and what I'm hearing and what you just said in terms of the upper reaches actually attempting to revise this. So, but I've been doing politics a long time, and I know that unless the people in this room and others across this province actually get your recommendations out into the public and create some political pressure on them, those who have a vested interest in making sure the status quo remains the same are going to be successful. So, you talked earlier about patient care or family care councils, and that's something we've been advocating for a while. We also know that in a lot of the facilities, even where my father was for 7 years, they exist, but they don't really have any power, and they don't have any ability to access information. So I'm hoping your recommendations include a requirement that they're not just there to raise money for a new sofa. This is often the case, but actually have a process internally that allows them to hear complaints, to know whether or not the food's there, whether or not there's enough staff on, if there's people off on sick leave, etc. So I'm seeing your nod your head, excellent.
Yes.
But then that needs to link further, and it goes to Shauna's point around there needs to be some way of resolving complaints in a timely manner that is appropriate. And so Shauna is not alone in being banned in the province. We know that there are a number of other people who've come forward to us that have, in my views, been completely abused in terms of the abuse of authority, if you will. The Trespass to Premise Act actually allows facilities to remove people, and they should have some power to do that. But there is no legal due process under the Trespass to Premise Act to become unbanned, to be able to say, wait a second here, I think feeding my mother or something or other should not be considered a banning offense, etc. So if the government's not going to act around the ability for due process to be put in place, then we have to be able to force that in other ways. And I would suggest that a family care council could be an initial first step where they can say, well, so-and-so is had gone through this process, review that, and then making sure that there are other needs in place. And so, but you've certainly touched on a lot of the key issues that we've heard for the last 10 years, and hopefully we can communicate around how do we get some political will to make that happen, because I think we're on the same page there. Thank you.
Thanks very much, Bill. And I think I was listening to a podcast of you interviewing Neil Somerville, and I had my office door shut, and people were going back and forth because they could hear this man in my office because the volume was quite high on my computer. Anyway, I think the other thing that resonated with us very early on, we had a conversation with Carol and John, and they underscored the need to ensure that we include a strong focus on ethics and a strong focus on human rights in the work around continuing care. And I think that's resonated with what you people have said today. And we need to look at our processes and make sure that they're fair, that there is an opportunity for multiple points of view, and we're committed to doing that.
Okay, I'm going to ask Carol to wind up in a moment, but I've got one question for Nancy and Isabel. We've heard what you're doing. What would you like us to do?
You know, I think these kinds of discussions are so important. I think we need to get the conversation out into the public. It's great to have it in the basement of SAGE, but we need to get this conversation moving across the province. And you know, people need to, the awareness needs to grow around continuing care and how we can make it the best system. And I'm looking at Tara, and it's not just for seniors, right? We have, you know, a huge population of young people with autism, with very complex medical issues. in this province who are going to be requiring some sort of supportive care in the not too distant future. We have people with brain injuries. We have, people with spinal cord injuries. We need to look at innovative models. We need to grow this conversation, and we need to just the taboos need to disappear.
I think what we're also going to need from you is to actually really get out and tell your stories. And I'm not in Edmonton, but I come up here a lot, and my daughter lives here. But I think that there's getting back to that, having that conversation early. We have a really young population also in Alberta that we need to start to think about what is it going to be like for us in terms of our continuing care journey. So as Isabel said, getting the conversation out. We are going to be putting our recommendations together in a very, as directed by our CEO, which is one of our lines, keep it simple and keep it very streamlined. And so once we have got that in the right format, we would really welcome feedback from yourselves, and we're trying to just strategize how we're going to do that, since we've talked to over 900 people. And so, and we've kept notes on every meeting, so we have quite a large database. But really, whether we're feedbacking it through John and Carol, and they can have smaller focus groups, because we won't physically be able to be at every meeting, but the paper or the recommendations are going to be very simple. They're going to be easy to follow. It's not going to be a 150-page document. So your feedback, your suggestions, keeping the conversation alive would be the greatest gift that you could give us, and also just thanking us for allowing us to be part of this very incredible group that you have here.
Anytime you need us to man the barricade, just let us know.
Thank you very much. S.A.L.T's been in place for 20 years. It was created in response to the trashing and the demolition of our healthcare services, and particularly our senior services, back in the mid-90s. I didn't run head-on into it until the end of 1995. So that gives me almost 20 years. In that time, John and I both have had consultations with the government. I've met with more ministers of health than I care to remember, and some premiers that I wish I could forget. None of them have done anything except to make sure that I will never in my life have low blood pressure. Your conversation we had with you, first of all, your response to knowing that we had something to say and inviting us to sit down with you, was the most intelligent and respectful conversation we've had with anyone from the government in more than 20 years. So we have high hopes, very high hopes, because when the MLA task force did its report, as a result of 2 days, 2 evenings of meetings in this city, there wasn't one comment in it that came out of those sessions. So we don't expect to hear that from you. I run a news digest for interested persons, so every day I scan the news media, takes over my life. Every day, every week, I come across stories of neglect, abuse, negligence that affect our continuing care system and our healthcare system. It's poor planning, it's stingy provisions of inadequate services, it causes real harm to real people and to their families and to our community and to our sense of ethics and values, which really does worry me. The business about covenant health yet again reducing the nursing care in its facilities is so offensive, I can't tell you. I remember a meeting with Premier Stelmach in 2008. In fact, it was the day of the ducks, so he wasn't really paying attention to us. But he did say to us I don't want my mother in a hospital, and it doesn't take a registered nurse to wheel these people down to the dining room, so we're going to do away with nursing homes. And that's why we've got hospitals full of people who should be getting nursing care in skilled nursing facilities. And that's really, really important. And I don't think it should be left to the providers to decide that they want to be able to pay $250,000 salary to somebody by cutting the nurses in nursing facilities. Please put that into your report. Okay, that's my rant for the day. John will be delighted. We have done a report, a SALT perspective on continuing care, which went to the Minister of Health with a letter saying what we'd like him to do to change the system. And we'd like to give you each a copy. And if I haven't already, I will send you an electronic copy because it's full of references and you'd appreciate the links, I'm sure. So that's SALT's contribution. I had to keep it to 3 pages because most people can't read more than 3 pages unless it's a novel. But we will be talking about some other things before you finish your mandate. I want to thank you so very, very much for being willing to come and sit with us, for being respectful and for listening, and for giving us hope. Good luck to you.
Thank you, and if any one of you want to come up to speak to us personally about maybe a personal situation or that you're dealing with, please feel free to, and we'll stay back and be happy to speak with you. So thank you again for your time, and again for your honesty, and for inviting us into your home here at SALT.